This must be one of the most anticipated video that I've ever made on the channel, because I've got a lot of requests from all of you asking me to teach about HIV drugs and the regimen and the treatment guidelines in adults, treatment guidelines in children, and pretty much treatment guidelines in HIV. So lo and behold, here it is. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at HIV treatment in adults, the treatment guidelines as of the latest treatment guidelines at the time of publication of this video. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. So we have already looked at the HIV basics. We looked at diagnosis in adults. We also had an interlude where we looked at the HIV drugs. If you didn't watch the interlude, especially the interlude and even the part 1 and part 2, please head over there and watch them now before you actually continue with this video, because this is going to be very, very confusing for you and you will have very much difficulty understanding. The HIV drugs that I covered in the previous lecture prior to this actually looked at the different dosages, how these drugs work, and of course the important adverse effects. And then I won't cover much of that in this lecture because this is strictly just the treatment guidelines in adults. So at the end of these 6 videos, then you should be able to actually have a good idea of how we manage HIV patients in general. So in the vein of our new lecturing style, we start off with the warm-up question, which is a single best answer. A 5th-year medical student has acute retroviral syndrome 3 weeks after unprotected sex with a new partner. Her HIV diagnosis is confirmed with PCR. In reading about HIV drugs, she comes across a drug called Maraviroc. Which of the following HIV-1 co-receptors is targeted by Maraviroc? A. Cd4 receptor, B. T-cell receptor, C. CXCR4 receptor, D. Interleukin-2 receptor, E. CCR5 receptor. So take your time. You may pause the video, answer this. I will give you the answer at the end of the lecture, but of course I did talk about this in the previous video. So if you watch the previous video and you understand everything I talked about from there, you can easily answer this. So before you go any further, there are some recommendations that have been put out from the current guidelines. So the first and foremost thing is that any patient that is found HIV positive, regardless of their Cd4 count, regardless of their WHO staging, should be started on treatment. Way back, we used to wait for them to reach a certain level for us to actually start the treatment, but now there's no need for that. Then of course our current first line is going to be our Tenofovir Disoproxyl, which is TDF. Remember, there are 2 preparations, Tenofovir Alafinamide and Tenofovir Disoproxyl, plus XTC, which can either be Lamivudine, which is 3TC, or it could be emtricitabine, which is FTC, and dolutegravir, which is an integrase inhibitor. Now, this is going to be a current first line in all adults, as well as a preconceptual period before they get pregnant. Then, of course, genotypic testing is needed after you figure out that this patient has treatment failure. We'll talk about treatment failure later on in this lecture. And Darunavia boosted, ritonavir boosted Darunavia is going to be used now as a second line in the antiretroviral therapy. Now, in all the instances, every time you meet the patient, there should always be counseling on adherence and the benefits of starting antiretroviral treatment. Some of the things that you must allude to is that there is, of course, obviously a reduced risk of HIV-related morbidity and mortality, reduction in mother-to-child transmission rates through breastfeeding as well as during pregnancy. There's also a potential reduction in the incidence and the severity of chronic conditions, things like renal disease, liver disease, certain cancers, even neurocognitive disorders. There is a reduction in infection complications such as TB, as well as a reduced chance of sexual transmission. All these are benefits of someone who starts on effective ART and they become virally suppressed. So here's a flow chart of how we actually do things. So we first test the patient with the partner or with the family or just the patient themselves. Then, of course, we should assign them a national unique patient number. Then, if they desire so. Then, if they are HIV negative, then we do provide them with HIV prevention messages. We actually offer them PrEP or PEP, depending on the situation. Then, of course, we establish the partner status as well, and we retest them after every 3 months. Then, of course, if they are infected, then we should start cotrimoxazole prophylaxis if it's a child less than 5 years, if they are pregnant, if they're a child that are greater than 5 years, an adolescent or even an adult with a Cd4 count that is less than 350 cells per microliter, or a WHO clinical stage 2, 3, or 4. The first lecture that I talked about, we talked about the WHO clinical staging. So head over there if you've forgotten to remind you of the clinical staging. We should screen for TB, screen for cryptococcal meningitis because these are very common, screen for renal insufficiency because there are some drugs that you can't give in patients that have renal insufficiency. Then, of course, treat all patients, start them regardless of the HIV, regardless of the Cd4 count, regardless of the WHO clinical staging. But, of course, there should be some baselines that have to be done. The baseline tests have to be done. So what are some of these pre-initiation tasks that you're going to be doing? So we've pretty much split them into 3 visits before the patient starts treatment. We assume that the patient could start treatment at the first visit, the second visit, or the third visit. At least they should start treatment within 4 weeks of them having a diagnosis. The best actually is to start them on treatment within 2 weeks of them getting the diagnosis. But of course, some people have that time that they're given to go think about it, or maybe you want to run some tests, but ideally you should start them on treatment. So on the first visit, which is of course your enrollment or initiation of our ART-based regimen, depending on the patient's readiness, it could be a child, it could be an adolescent, or an adult. So if it's a child, you want to take your complete history and examination, screen for TB and other opportunistic infections, counsel them on adherence and compliancy each time you see them. Then, of course, WHO clinical staging, start them on cotrimoxazole prophylaxis if it's a child greater than 6 weeks up until they are less than 5 years. And then if they are greater than 5 years to 10 years, they are only eligible if their Cd4 count is less than 350 cells per microliter. Then, of course, initiate them on prophylaxis against TB if they do not have TB. That's your rifampicin, but isoniazid prophylaxis. Then, of course, the HPV vaccine for girls that are less than 10 years. Then with adults, you want to also do a complete history and physical examination, screen them for TB and opportunistic infection, stage them according to the WHO clinical staging, initiate them on cotrimoxazole prophylaxis if they have a Cd4 count that's less than 350 cells per microliter, or if they have a WHO clinical staging that is either stage 1, 2, 3, 2, 3, and 4. This must have been a typo, or if they are pregnant. Then also initiate TB prophylaxis if they don't have TB. If they have TB, you have to treat TB because you don't want to treat TB with just isoniazid. Perform a urinalysis as well. Some lab tests that you should order for: creatinine, so that you can be able to calculate the creatinine clearance, ALT, HB or full blood count, Cd4 testing. Then, of course, hepatitis profile, especially hepatitis B if they are not vaccinated. Then, of course, a pregnancy test. All women that are of childbearing age are considered pregnant until proven otherwise. So you who's watching the video are pregnant until you're proven otherwise. Get a syphilis test in adolescents or adults, cholesterol and triglycerides, especially if you're going to be starting them on protease inhibitors. Then, of course, HPV testing testing, or you can do a visual inspection under acetic acid in those that are sexually active or adolescents or women. Then, of course, in the second visit, which is usually 1 to 2 weeks later, we can initiate them on ART if they are not yet initiated on ART at the first visit. So I want to get a targeted history and examination, screen for TB, screen for Cryptococcus, screen for pneumocystis jirovecii pneumonia. Then, of course, review the adherence of cotrimoxazole if they started on cotrimoxazole the first time they visited. Then, of course, initiate them on cotrimoxazole if they are eligible but did not start the first time that they visited, and TB prophylaxis if they didn't start the first time that they had started. Then, of course, review the lab results. If for those that you took at the first visit, then initiate them on ART if they haven't been started at the first visit. Continue counseling them on adherence and compliancy. Then, of course, you can order for a urinalysis or do a urinalysis, get sputum for acid-fast bacilli stain or GenExpert, for multi-drug resistant TB or Mycobacterium TB, and then also in individuals with a positive screening, for example, those that have contacts of TB or those that have constitutional symptoms of TB. Then, of course, order for a serum cryptococcal antigen test for adolescents and adults with a Cd4 count that's less than 100. Then on the first visit, which is usually 2 to about 4 weeks after you enroll them into this program, again, if they haven't started treatment, you can start them then on treatment. Get a targeted history, screen for TB and other opportunistic infections, review adherence to your cotrimoxazole, TB prophylaxis screening, or screen for TB, and then, of course, put them on prophylaxis if they're at risk, or if they haven't been started, initiate ART if they haven't started, continue adherence and counseling. In every visit, make sure that you're talking about adherence and counseling them on adherence and compliancy. Then, of course, urinalysis, sputum for acid-fast bacilli, your serum cryptococcal antigen test in adults and adolescents with a Cd4 count less than 100 cells per microliter. So this is what you do before you start them on treatment. Even when you start them on treatment, you should make sure that all these tests are ordered for. Now, there are some cases where you actually start them on ART the same day that they are found to be positive. So you get tested, then you find out that the individual is positive. So, of course, we're going to be counseling them after the test and giving them some education. Getting a brief history, ask them about fever, weight loss, cough, persistent headaches, history of kidney disease, hypertension, diabetes, acute or chronic diarrhea, use of NSAIDs like ibuprofen, diclofenac, aspirin, and endomethacin, or any use of any herbal medication. Get a clinical examination, check this patient's BP, their weight, their height, their BMI, and of course do a random blood sugar and a urinalysis. Then, of course, ask yourself, is the BP greater than 140/90? Do they have hypertension? Is the BMI less than 18.5 kilograms per square meter? Do they have severe acute illness? Is there any chronic use of NSAIDs or herbal medication that can cause renal insufficiency? Is there proteinuria of at least 3+ on the dipstick? And is there random blood sugar greater than 11.1 on the glucose stick? Now, if the answer is no to all these questions, then you can actually prepare this patient for the same day initiation of ART. So you can start them on tenofovir with either the TDF or the TAF, plus XTC, which is either the lamivudine or emtricitabine plus dolutegravir. Now, if they are HIV positive and they have TB and they are on rifampicin, then of course you want to avoid the TAF, and then of course increase the dosage of DTG to 50 milligrams, because of course the drug-to-drug interaction between DTG and rifampicin, of which I talked about in the previous video. Then of course, if there is evidence of the above, then you should prepare them for the same day ART, so screen them for TB and cryptococcal. If they are positive, start them on treatment of those, and then defer the treatment of ART because you want to prevent iris. Then of course, if there is evidence of renal disease, you want to replace TDF with TAF or ABC. And then if they are pregnant or have TB, avoid TAF. So pregnant women, I just advise you to actually start them on an ABC regimen. And those that have TB, it will be better off starting them on an ABC regimen. That's if you can't consult. Then, of course, if the patient is not ready to start ART, discuss the reasons why and schedule them to come back at least a week after. Draw bloods for your baselines, so your Cd4 count, your creatinine, your hemoglobin and full blood count, hepatitis B, RPR for syphilis, ALT and AST for the liver enzymes. Then, of course, send them for testing and review them within 2 weeks to discuss the lab results. Now, when you get back the lab results, you should calculate the creatinine clearance, of which I showed you how to calculate in the previous video. If it's greater than 50, you can continue TDF. If it's between 30 to 50, replace TDF with TAF. If it's less than 30, then replace the TDF with ABC, and then also adjust the dosing of lamivudine. So ABC, lamivudine, as well as dolutegravir. And then, of course, if the creatinine clearance again is between 30 to 50, continue them on TAF. If it's less than 30, otherwise change them to your TAF change your TAF to with ABC and adjust the dose of lamivudine. Now, what are the first line regimens? So remember that this is going to be providing an optimized fixed dose regimens in all populations, and this has actually shown that you get better clinical results, you get better laboratory outcomes if you start the treatment early. It reduces the time, we want to aim to reduce the time between the diagnosis of HIV as well as the initiation of the combined antiretroviral treatment. Now, this is based on the assessment of the patient's readiness, as well as it's preferred that we initiate these patients on treatment at least within 2 weeks. So this is the first line treatment, and these are the first line drugs with the alternative regimens. So we'll start with our pregnant and breastfeeding women. So all patients that are pregnant, all patients that are breastfeeding, you can start them on TDF, XTC, and DTG. Although in the previous video I did mention that TDF should be avoided in pregnancy, we still can use TDF in pregnancy. What you want to avoid in pregnancy is TAF, Tenofovir Alafinamide. So you want to start them on TDF, XTC, which is either emtricitabine or lamivudine plus dolutegravir. An alternative regimen is giving your TDF, XTC, and efavirenz. Now, this efavirenz that you're giving is not the 600 milligrams tablet, but rather the 400 milligrams tablet. Or you can use your ABC, 3TC, and DTG. Now, this one is used as an alternative for patients that have renal insufficiency and for patients where TAF is not available and efavirenz is also not so tolerated. Then you can use this as an alternative regimen. Now, in adolescents between 10 to less than 19 years and those weighing greater than 30 kg, and in adults, the first line preferred regimen is either your TDF or your TAF. Remember that TAF is going to be used when you have your creatinine clearance that is less than between 30 to 50, then we use our TAF. If it's greater than 50, you can use TDF, meaning that there is no renal insufficiency. Then, of course, your XTC, which is either lamivudine or your emtricitabine, and DTG. So generally, if you get a patient that is HIV and TB and they are on rifampicin and they can't really tolerate efavirenz, then you will have to increase the dosage of DTG to twice a day. Usually we take the dolutegravir as once a day, so we want to actually increase it to twice a day. So we give them 50 milligrams twice a day, because remember that there is a drug-to-drug interaction between rifampicin and dolutegravir. Then, of course, our alternative regimen is going to be your TDF or TAF, depending on whether they have renal insufficiency or they don't, plus XTC or plus efavirenz 400, but this is not really a common combination that we usually use in adults. Or we could use an alternative that's ABC, 3TC, and dolutegravir. So this is our preferred first line. So let's just go through the footnotes here. So your efavirenz 400 is a lower dose of efavirenz, 400 milligrams per day, and this is preferred for people that have HIV and TB and they're on treatment. Then, of course, if they're exposed to nevirapine, okay, so if they have been on nevirapine, then you want to start them on a protease based therapy. But of course, this is not relevant to this case. It's going to be very relevant when we look at treatment in pediatrics. Then, of course, Tenofovir Alafinamide, avoid that in pregnancy, avoid it in HIV patients that are on rifampicin. We do not have enough data to actually safeguard its use. Then, of course, XTC can either be 3TC or FTC. 3TC is lamivudine, FTC is of course your emtricitabine. So if FTC is not available as a single drug, then you can and is expected to be part of the fixed dose combination, then we can give your TAF, FTC, and your DTG. Then, of course, DTG can be given to those that are naive, that have never taken any antiretroviral treatment before. Then, of course, for those that have HIV with TB, and then, of course, they are on rifampicin and they cannot tolerate the efavirenz 400, we increase the frequency to 2 times a day as opposed to once a day. I hope that makes sense. Now let's talk a little bit about dolutegravir. So remember that this is a newer integrase inhibitor. It has a higher genetic barrier to resistance compared to the other integrase inhibitors like raltegravir and elvitagravir, which is, as well as other non-nucleoside reverse transcriptase inhibitors. So DTG is actually associated with the following mutations. You have the F121Y, E138, AK, G140SA, Q148, HKR, N155H, and the R263K. So cross-resistance can actually happen with the earlier drugs that we discovered, or the earlier drugs that were formed for the integrase inhibitors. So the cross-resistance viruses indicate that our G140S and our Q148H KR in combination with other mutations such as the L741M and the E92Q and the T97A, as well as the E138AK and the G140A, as well as the N155H, have been associated with 5-fold and even 20-fold reduced susceptibility to dolutegravir and reduced virological suppression in patients. So if you have these core mutations that are happening, then that's a very, very big problem. So we want to dose our dolutegravir at 50 milligrams once a day, except for patients that are on rifampicin or those that have integrase mutations, where we want to give it twice daily. There is no food requirement, and the drug has a few interactions. Now, the reason why we're doubling the dose when we give it rifampicin is, remember that DTG is metabolized by UDP glucuronil S transferase, and UDP glucuronil S transferase is induced by rifampicin. So it means if you're giving both drugs, rifampicin will stimulate this enzyme to break down a lot of the DTG, so this will lead to lower levels in the plasma. That's why we give double the dosage. And of course, it's decreased by absorption. It has decreased absorption with aluminium, calcium, or magnesium containing antacids, so it shouldn't be taken with those. Then of course, there is a reported increase in serum creatinine with no true effect on the filtration rate. There is no efficacy data on the use of DTG in adolescents younger than 10 years old, so we don't have that significant data as of now. Now, DTG can be given to women of childbearing potential. Now, the benefits greatly outweigh the outcomes. So, DTG-based regimens are recommended as first line to women that are living with HIV in Zambia, including women of childbearing potential, as well as the children weighing above 20 kg. Now, the benefits of DTG is that it has it suppresses the viral load very quickly, and there are fewer maternal deaths, fewer sexual transmissions, and also fewer mother-to-child transmission. One side effect, though, is that it may result in neurotube defects, but of course the risk of this is very minimal, and actually the evidence shows that the risk of the neurotube defects in DTG use is significantly less than what we actually previously thought it was. So once a woman has been found with HIV, we should counsel her on the benefits and the risks of starting DTG, and she should choose with autonomy. No clinician should force any drug on any patient. And of course, as she's taking the drug, there should be some active pharmacovigilance that must be done. Now, here are some practical hints about using DTG. So remember that we can use it in all the populations: adolescents above 10 years, adults. Then, of course, in adults and adolescents with HIV type 1 or HIV type 2, a mixed infection, then we can start them on our usual first line, TDF or TAF, depending on whether they have renal insufficiency or not, XTC plus DTG. This is what I've been preaching all along. And of course, if it's an adult or adolescent with HIV-1 who has an undetectable viral load and they were previously on the non-nucleoside reverse transcriptase as a first line, for example, patients that were on TDF, XTC, and efavirenz before, this is known as sometimes we refer to this as a TLE regimen. So these are patients, for example, that were on atripla, if I'm not mistaken, which should have been tenofovir, lamivudine, and efavirenz. So we can actually switch them to dolutegravir. So we just replace the efavirenz with your dolutegravir. Those that are on nevirapine, again, replace that with dolutegravir. Those that are on ABC regimen, we continue them on an ABC regimen. So ABC, XTC, and dolutegravir. and those that were with nevirapine, ABC, 3TC, and dolutegravir. Most likely, they were put on an ABC regimen because of a reason. It could be that they had some renal insufficiency. Then in adults and adolescents with HIV-2 or the mixed infection who have an undetected viral load whilst they are on protease inhibitors as the first line. For example, we had patients that were on TDF, XTC, and boosted lopinavir. Then, of course, we can continue them on our first line regimen. And those that were on an ABC regimen, we continue them on an ABC regimen, but we substitute the boosted lopinavir with our dolutegravir. I hope that makes sense, and I hope this is making a lot of sense. If it is, please comment in the section below. And it's so much feedback from you that is positive. It's actually very encouraging to do these videos. Then, of course, in HIV and TB infected patients who are on rifampicin and they can't really tolerate efavirenz 400, then we want to switch them to our TDF, XTC, and dolutegravir. But remember, we want to increase the dosing of the dolutegravir to twice a day instead of once a day, because rifampicin actually stimulates the metabolism of dolutegravir through the UDP glucuronil S transferase enzyme. Then this switch should be done if the viral load is less than 1,000 copies. If it's greater than 1,000 copies, then you want to actually consider switching them to a second line regimen. Now, our second line regimen is either our zidovudine, remember this was moved to second line, zidovudine, lamivudine, and dolutegravir, or zidovudine, lamivudine, and boosted lopinavir. Then, of course, we increase the frequency of dolutegravir. I've already talked about this. Then, of course, the dose of lopinavir should be doubled. However, where the single 50 milligrams tablet is available, then we should switch them to your TDF, XTC, and your boosted lopinavir, those that were on efavirenz initially and they can't really tolerate efavirenz. Now, dolutegravir significantly also increases metformin levels in plasma, so it means that patients that are on metformin and dolutegravir, there should be an adjustment in the dose of metformin. Why is this so? Partly it's because you have the OCT transporter, your organic cation transporter 2, that is inhibited, such that now there is more metformin that remains in the blood. So it's recommended that we adjust the doses of metformin to actually maintain the optimum control of the sugars as when the patient is starting or stopping DTG while it's taking metformin. If a patient is taking DTG who is starting metformin, then we begin with a lower dose of metformin, then we titrate it upwards. So the recommended dose limit is about 1,000 milligrams a day. And if the patient is already on metformin and initiating our dolutegravir, then we want to monitor our glucose, monitor our hemoglobin A1C. We also want to monitor for the adverse effects of metformin, as well as adjusting the dose as needed. Then the next drug is Tenofovir Alafinamide, which is pretty much a phosphonoamidated prodrug of the nucleotide analog tenofovir. So it belongs to, of course, the class of nucleoside reverse transcriptase inhibitors, and it's predominantly going to be metabolized within the cells. Now remember that it's going to be metabolized to form tenofovir, which is of course going to undergo subsequent phosphorylations to yield an active form of tenofovir, which we call as a tenofovir diphosphate. Now, this metabolite is the one that's going to be active against HIV and actually blocking the reverse transcriptase, competitively inhibiting the reverse transcriptase and causing the chain termination. I talked about all this in a lot of details. Now, remember that the dose of Tenofovir Alafinamide is 25 milligrams once a day when it's used without any pharmacoenhancers. And remember that Tenofovir Alafinamide has demonstrated both in vitro and in vivo activity against hepatitis B, so it does also work against hepatitis B. The median terminal half-life of the drug is about 0.51 hours, and the active metabolite, which is your tenofovir diphosphate, has an intracellular half-life of about 150 to about 180 hours. And remember that it's going to be metabolized in the hepatocytes, the peripheral blood mononuclear cells, the macrophages, and to a lesser extent, less than 1% of the dose is excreted in urine, and most of it, 31.7%, is excreted in the feces. Now, it has been associated with certain mutations such as the K65R and the K70E substitution, which actually lead the virus to have reduced susceptibility to abacavir, didanosine, emtricitabine, lamivudine, as well as tenofovir disoproxyl. Now, HIV type 1 containing multiple thymidine analog mutations, such as these ones listed on the screen, can actually lead to resistance to Tenofovir Alafinamide. And in addition, you may have some multinucleotide resistant viruses with a double T69S double insertion mutation, or just a Q151M mutation complex that includes our K65R. These can actually exhibit some form of resistance to Tenofovir Alafinamide. Some adverse effect are diarrhea, fatigue, nausea, rash, just to remind you. Then of course it's associated with significantly less increase in proximal tubular proteinuria, which is why we use it in patients that have the 30 to 50 creatinine clearance. Then of course there is less reduction in estimated glomerular filtration rate as compared to TDF, which is why we can still use this drug. And of course, it is associated with significantly less changes in the spine and the hip bone density as compared to TDF, but there is no safety data that has been there on patients with pregnant women, and then on patients that have TB and HIV as a co-infection. Now, here are some practical hints for using Tenofovir Alafinamide for those that have HIV type 1, type 2, or a mixed infection. Of course, our standard treatment, TAF, XGC, and DTG. We're assuming that this patient probably has a renal insufficiency where they have a creatinine clearance between 30 to about 50. Then of course, in adolescents with HIV type 1 who have an undetectable viral load but were on a non-nucleoside reverse transcriptase as a first line, then of course your TDF, XGC, favirenz, you change it to your TAF, XGC, and DTG if they have some renal insufficiency. Then TDF, XTC, and nevirapine, we change it to TAF, XTC, and dolutegravir. And then if they were on an ABC regimen, we can still put them on TAF, depending on looking at the creatinine clearance. If the creatinine clearance is less than 30, then we still should maintain them on the ABC regimen. And of course, we add your dolutegravir and continue the XTC, which is either lamivudine or emtricitabine. Then, of course, for those that have HIV type 2 and were previously virally suppressed on a protease inhibitor as a first line, then we want to switch. If they were on TDF, lamivudine, and boosted lopinavir, we change them to TAF, XTC plus dolutegravir. Same thing if they were on an ABC regimen. It's not recommended for use in HIV and TB infected populations, so we want to avoid that. And it is recommended that such patients are started on a TDF or an ABC regimen instead of TAF. So if they have TB, if they have TB and HIV, don't start them on TDF, or rather don't start them on TAF, but rather start them on TDF and an ABC regimen. Then of course the use has not yet been sanctioned for pregnancy, and it is recommended that patients that are pregnant, we should switch them to an ABC regimen or TDF as opposed to them being on a TAF regimen. Then for simplistic methods, the patients that are started on TAF are women that are 45 years and above, men that are 50 years and above, those that have a creatinine clearance between 30 to 50, children above 25 kilograms, and all those that are initiated on TAF must continue TAF unless there is a contraindication. Then here are some practical hints for using the efavirenz 400 milligrams. Remember that this is a reduced dose. So the efavirenz 400 is actually used as an alternative to your DTG in adults and adolescents that are being initiated on ART, including those that are pregnant and breastfeeding and those that have TB. So we can consider our efavirenz 400s in patients that have TB and HIV that are on rifampicin, because remember DTG is pretty much reduced its efficacy when you're co-administering it with rifampicin. Then of course the 600 milligrams is going to be associated with the CNS side effects that we talked about, so your dizziness, your drowsiness, your insomnia, your vivid dreams, your impaired concentration. Then of course in systemic reviews that we have actually done on different researches, there has been some evidence that if you compare the efavirenz 400 milligrams with the efavirenz 600 milligrams in terms of viral suppression, it's had a better viral suppression, it's rather comparable, not really even better, but rather comparable viral suppression, but not as optimal. But it actually was better in terms of the Cd4 count recovery, and also protective in terms of the treatment discontinuation because of the side effects. Then when compared with the standard dose of efavirenz, the 600 as compared to the 400, of course there are lower toxicities, there's a smaller cost, of course the pill is also even smaller, and it's also comparable to other treatment regimens with respect to mortality or AIDS defining illnesses and emergence of serious adverse effects. Then if the CNS effects actually persist beyond 6 to 8 weeks on the 400 milligrams tablet, then we substitute them with a protease based regimen. That's if DTG, they can't really tolerate DTG for some reason. Then it should be avoided to take it with fatty meals. So take it 4 hours before any fatty meals or after any fatty meals. And it's recommended that you take it before bedtime. Then, of course, efavirenz should not be used to treat patients that have an HIV-1 and HIV-2 as well as HIV-2 infection, because it's not so effective against HIV type 2. Now, here's an algorithm for choosing whether you're going to be starting on DTG or efavirenz. So our primary integrase inhibitor is a DTG. Is there any contraindication for them starting DTG? No. If there's no contraindication, we start them on DTG. If there is, we start them on efavirenz. What are some of the contraindications? If there's significant insomnia, anxiety, depression, hypersensitivity reaction, if there's co-infection of TB and efavirenz 400 cannot be tolerated, then DTG is going to be used. And in this case, we want to double the dose, the 50 milligrams twice a day as opposed to giving it once a day. Now, the other drug that is now moved to second line, or the other drug that is part of this, the second line, is Darunavia, boosted Darunavia. So it's ritonavir boosted Darunavia. It's a protease inhibitor. And the efficacy and the tolerability of this drug is actually much, much more superior to lopinavir-ritonavir combination and atazanavir with ritonavir. So until recent widespread adoption of the Darunavia, the boosted Darunavia, it's been actually hampered by the lack of affordable generic fixed dose combinations. It's not so available, even in the country, not so much. And of course, Darunavia has virological outcomes that are actually quite comparable to raltegravir as well as boosted atazanavir, and there's a lower discontinuation rate compared to atazanavir. Now, it has a higher viral suppression rate and fewer discontinuations compared to boosted lopinavir, and it can be used in third line after someone is on treatment failure when they were on a protease inhibitor. And then, of course, with increased dose given the higher barrier to resistance. Then, of course, the recommended oral dose in adult patients is as follows. So those that have never taken protease inhibitors before, you can give them a combination of a tablet that is 400 to 50 taken once a day, or the two tablets of this, or you can give them one tablet which has the combination of 800 to 100 milligrams. So the 800 is the Darunavia, the 100 is of course the ritonavir. And of course, in those that have been exposed to protease inhibitors, including third-line patients, Darunavia 600 milligrams is taken with ritonavir 100 milligrams twice a day. And of course, pregnant women, Darunavia 600 with 100 milligrams twice a day is taken, except where the viral load is already suppressed. Then we just increase, the increase in the dose will actually be detrimental to adherence. Or if it's not available, then we pretty much give them your 600 milligrams and 100 milligrams of ritonavir, respectively, twice a day. Then, of course, Darunavir must be administered with food to, of course, achieve the desired antiviral effects. Some adverse effects include diarrhea, nausea, rash, headaches, abdominal pain, vomiting. Then, of course, discontinuation of Darunavir immediately if the signs and symptoms of severe skin rash develop, including but not limited to things like severe rash or rash that's going to be accompanied with a fever, malaise, fatigue, muscle or joint pains, blisters, oral lesions, conjunctivitis, hepatitis, or even eosinophilia. Now, patients that have suspected or they have an underlying liver disease should be monitored. You should check their liver enzymes during the first few months of treatment. Then, of course, there should be some precaution that is taken with if you're taking drugs like Darunavia with drugs that actually are metabolized by your cytochrome P453A isoenzyme, because it's affected by this. So drugs like TB drugs, rifampicin, antibiotics like clarithromycin, antifungals like fluconazole, antiepileptics like phenytoin. There is a drug-to-drug interaction that I also looked at in the previous lecture. Then, of course, the combination of Darunavia and artemether lumefantrine, that's your coatem, can actually be used without dose adjustments. However, the combination actually can be used with caution, as increased lumefantrine can actually cause QT prolongation, actually predisposed to your arrhythmias in the heart. And of course, effective alternative contraceptive methods should be used, because once you co-administer this, they decrease the effectivity of the contraceptive pills. Then, what are some of the practical hints when we use Darunavia? So it's recommended in patients that are failing first-line DTG-based regimen. Then Darunavia may be given in combination with DTG. Darunavia can be used after a patient was already on atazanavir, was already on lopinavir. Then, of course, if they are failure, then you want to administer a much higher dose, the 600 to 100, twice daily. Then, of course, Darunavia should not be used in HIV TB infected people when the TB treatment includes rifampicin. Then it is recommended that such patients actually receive lopinavir instead, the boosted lopinavir instead of the Darunavia. And of course, Darunavia may be used in TB treatment if they are using rifampicin, or in drug-resistant TB where rifampicin is not part of the regimen. Now, there is this that has been going around that I saw an image of, where they say that they have designed a drug that they can inject you with, and then you go for some months without, or some weeks rather, without actually having to take some tablets. So it's like a long-acting injectable ARVs. So this are going to be consisting of two drugs, cabotegravir, and of course this that I'm not going to try and pronounce, and these are actually pending approval for widespread use. So once this has been approved, then they'll be rolled out, and even Zambia can start using them, of course, with special populations. And by special populations, you already know who is going to be receiving them first. I will not start with all that in this video. Now, what about HIV type 2 treatment? So remember that clinicians, even in type 2, should use the same regimen that we use in type 1. So your TDF or your TAF, XTC, and DTG. If they are unable to tolerate DTG, then you're not going to substitute it with efavirenz, because efavirenz is not so effective. We're going to be substituting it with ritonavir boosted lopinavir on a prescribing arch for especially those that have HIV type 2 and those that have the mixed infection. Then, of course, do not prescribe nevirapine, efavirenz, or even other protease inhibitors like atazanavir, because they're not so effective against HIV too. We should consult with a provider, an advanced treatment center, the management of HIV type 2, consult your infectious disease specialists. And of course, where there is doubt, before you initiate the ART in HIV type 2, that's if you find that this patient has type 2. And of course, educate the patient with the type 2 infection and the types of drugs that can be used to treat it, because most people think that HIV is just HIV after all, but there are two types of HIV. Then there are no randomized clinical trials that haven't been conducted to determine when to initiate ART as compared to HIV-1. Everything that we've been talking about mostly has been for HIV type 1, and the best treatment therapy that we can use in HIV type 2, that's still under study. And then, of course, there is no optimal strategy for treatment, and there are no recommendations from the experts that actually can guide you conclusively. And of course, HIV type 2, remember that it's less aggressive, it slowly progresses to AIDS, and then of course the response to treatment also, we can't really predict when the progression occurs. Even the response to treatment is very difficult to actually monitor, and the standard methods and the interpretation protocols that we use to monitor treatment against HIV type 1 may not actually even be applicable to those that have HIV type 2. And of course, some antiretroviral regimens that are used to HIV type 1 are not so effective in HIV type 2. Then of course, you should consider certain factors. The majority of HIV type 2 patients are long-term non-progressors. I talked about this in the first lecture. Then those that have HIV type 2 may actually confer a more rapid resistance to our ART agents because of the wild genetic sequencing that results in significantly increased resistance to ART ART agents as opposed to HIV type 1. And the pathways of which the mutations actually develop are very different with HIV type 1 and type 2, which is why there are all these different things that we can actually see. Now, what are the drugs that we use in HIV type 1 and type 2 co-infection in adults and adolescents? The first line is still the same. So TDF or TAF, remember that TAF should be avoided in those patients that are on rifampicin and have TB, those patients that are pregnant. Then, of course, TAF should be used in patients that have a creatinine clearance between 30 to 50. Otherwise, if it's greater than 50, TDF can be used, XTC and dolutegravir. And then, of course, dolutegravir is effective against both HIV type 1 and type 2. Some alternative regimens are your TDF or TAF, XTC plus a boosted lopinavir. Now, remember that lopinavir the ritonavir boosted lopinavir is actually the only protease inhibitor that works against HIV type 2. Or you can use your boosted Darunavia. Then, of course, we can substitute with ABC, 3TC, and boosted lopinavir or boosted Darunavia. Of course, these haven't yet even been studied as extensively. And then, of course, ABC, 3TC, and your dolutegravir. So now, if you're using this as an alternative regimen, you should use this especially in patients that have renal insufficiency. Then in children, we use our ABC, 3TC, and our boosted lopinavir, ritonavir boosted lopinavir. Now, what's the efficacy of ARV treatment in patients that have type 2? Of course, there are different classes here. You can actually have a look at this. I'll actually leave this on the screen. You can actually pause the video right now, have a read through it. It's actually quite interesting to see about the different researches that have been done. But what we have actually realized is from the protease inhibitors, the only one that is actually quite effective is lopinavir. And remember that we should double the dose of lopinavir in patients that are on rifampicin-based treatment and being treated for TB. And of course, with the integrase inhibitors, dolutegravir is effective against both HIV type 1 and type 2. And of course, some viruses can express the CCR5 receptors. And of course, Maraviroc can actually be used in HIV type 2 infection because it does express some of these receptors. But of course, there are different other co-receptors that are expressed. And of course, HIV type 2 is resistant to enfuvirtide, so it's not going to work. Then of course, the non-nucleoside reverse transcriptase inhibitors, most of them are actually have limited activity and rather develop resistance. So you can actually have a read through this and look at the efficacy. It's actually a very good read. Then how do we monitor clinical monitoring and laboratory monitoring? So these are the two components that we use when we're monitoring patients that have HIV. So clinical monitoring is going to be including our history and examination, as well as evaluation of adherence, side effects, and relative drug toxicities. Then our laboratory monitoring is going to be checking for these routine tests. So Cd4 count, viral load, and toxicity monitoring. Why do we do this? We want to evaluate the response to treatment and the diagnosis of treatment failure early on. We want to evaluate adherence. We want to screen for pulmonary TB. We want to detect any toxicities to the ARVs. Then of course, the viral load is actually recommended as a preferred monitoring approach because it's a better proxy to the performance of ART in an individual as opposed to the Cd4 count. Now, viral load monitoring in patients that are on ART. So if the patient has been on ART for at least 6 months, we should do viral load at certain instances. So now if the viral load is less than 1,000 copies, we continue adherence support and continue the ART. Then of course repeat the viral load at 12 months after initiation, and then routinely annually do the viral load. Then of course, if it's greater than 1,000 copies, it means that they are not virally suppressed. Then it means that you have to enhance the adherence. Then of course, we repeat the viral load within 3 months after the last viral load. Then if it's still greater than 1,000 copies, they have virological failure. So if they are on first line, we switch them to second line. We collect blood and do genotypic testing. Remember, there are two types of testing: phenotypic testing and genotypic testing, which I did talk about in the previous videos. And of course, we modify the second line ART according to the genotype results. Then of course, if they're on second line, then we do genotypic testing and we actually consult the advanced treatment centers. So what's the genotype test after HIV failure? Remember that the genotype test actually is going to be informing the clinician on the type of the drug-resistant mutations that are present, and it also helps them to actually select the appropriate drug for therapy. So this routine testing is actually very important for surveillance of HIV resistance in different populations. Then HIV resistance testing should be done in all patients after treatment failure and have enhanced adherence counseling with a repeated viral load that is still not yet virally suppressed. So the test must be performed only on patients who have evidence of adherence to the ART for at least 30 days. Then, of course, it should not be done on patients who are not currently taking ARVs, even though their viral load is high. And such patients actually should be subjected to enhanced adherence counseling until there is evidence that the ART is not working, they're not virally suppressed. So patients that are failing to actually suppress their viral load on the first line that has been taken religiously should be switched to the second line, then without actually even waiting for these genotypic results. Then the second line regimen can actually be modified once you receive the results, the genotypic results. Now, the genotype results are interpreted using a standard software that's known as a Stanford database, and these they're used to modify the results must be done in consultation with an HIV specialist, a physician or pediatrician that's experienced in managing HIV drug-resistant cases. Then, of course, there are some centralized laboratories which actually can perform this. UTH actually does this, and so on all genotype test sampling must be actually carried using a cold chain. So it should be kept at minus 20 degrees Celsius using nitrogen or dry ice. It should not go above this, it should not go below this, because the virus will be rendered ineffective. Then what's the viral load monitoring in pregnant and breastfeeding women? So if they are known positive patient on ART greater than 3 months, then we check the viral load if the viral load is on the file. If not, we trace the results. If the viral load result was greater than 3 months, so we do another viral load and we retest every 3 months. Remember, pregnant women are tested every 3 months. Then if pregnant, then we book them for viral load retesting within 4 weeks before the expected date of delivery. If the viral load was done in less than 3 months ago, then we do a viral load at 3 months from the last viral load, or retest every 3 months. And then if they're pregnant, we book for viral load retesting within 4 weeks of the expected, or before the 4 weeks of before the expected date of delivery. If the viral load is not found, then we do the viral load, retest them every 3 weeks, and we book them for viral load testing 4 weeks before the expected date of delivery. If they are a known positive patient less than 3 months and newly diagnosed, we do our viral load at 3 months from the last viral load, we retest at 3 months, and then of course, if they are pregnant, we book them for viral load retesting 4 weeks before the expected date of delivery. Now, what are some of the clinical and laboratory monitoring tests that we do? We already talked about this enrollment and ART initiation. We talked about this segment here. Then we talked about the week 2 post-initiation. Okay, we talked about this. So targeted history, screen for TB, cryptococcal, adherence, and side effects. And then, of course, review the labs. And then serum creatinine, urinalysis. We do the same thing at week 4. We do the same thing at week 12. It is a bit different thing that you do on the clinical aspect, but the lab results will pretty much be the same. So we review adherence and side effects and toxicity, adherence counseling. Then, of course, review any lab tests. We refill the ART with enough supply for the next 3 months. So the maximum that you can give is 3 monthly visits, 3 months. Then, of course, it's 6 months. We continue counseling on them on adherence, and then we repeat the viral load at the Cd4 count. We order for serum creatinine if they are on TDF, urinalysis if they are on TDF, then cholesterol and triglycerides, especially if they are on a protease inhibitor based regimen. Then, of course, 12 months post initiation, and every 12 months we should do a viral load, Cd4 count, serum creatinine, urinalysis, cholesterol and triglycerides. So once the patient has now clocked a year, then we do these tests yearly. Then in pregnant and breastfeeding women, we of course get your history and antenatal. I'll talk about this in detail, especially when we talk about treatment in pregnant and breastfeeding women. So if you do not understand it at this point, I will talk about this later on in much more detail. So I won't actually labor much on this aspect here. So how do we monitor side effects and toxicity? So we can actually change the ARV drugs, should be done only if there is review of adherence. The indication for changing needs to be addressed. So a specific ARV can be changed or substituted if there's toxicity like anemia, peripheral neuropathy, lipodystrophy, liver or renal abnormalities, intolerance or unresolved and prolonged side effects. If there's poor adherence, change indicated only to simple dosing schedule and to improve the adherence. And of course, the occurrence of active TB. So of course, we should change them. I'll talk about this when we talk about TB and HIV together later on. Then, of course, if there is failure, which can either be clinical, immunological, or virological, I'll talk about this. And when a patient is switched to an alternative regimen, the goal is to achieve viral suppression and to avoid any adverse effects, as well as optimize the adherence. Always do viral load and always ensure that the patient is suppressed before you switch across cases. Then we talked about some of these common side effects that may be associated with these drugs, so I will not labor much on this slide. Then what about safety monitoring? So pharmacovigilance is going to be relating to a science or activities of relating to detecting, assessing, understanding, and even preventing any adverse effect or any other drug-related problem. So remember that patients that are on any drug must be monitored. Especially, this is going to be a critical component of Zambia's national patient monitoring system, as the knowledge of these adverse drug reactions as well as these adverse drug interactions are going to be helping create a safer environment, especially for people that are living with HIV. So healthcare workers, recipients of the care, consumers, manufacturers, distributors, and even the general public are all encouraged to report any issues concerning drugs, to report any issues concerning adverse effects, medication errors, and even quality problems. And then everyone is encouraged to actually report this as soon as possible. When you're doing this reporting, there are many ways in which you can do this. You report to the Ministry of Health, which has put into place various systems through the ZAMRA, which is the Zambia Medicine Regulation Authority, and these tools are going to be your paper adverse drug reaction report that you can fill in, and you can access this from your local pharmacy department. Then of course your mobile phone applications like MedSafety, which can be found on Android and even iOS platforms, it can be found in the Play Store and even the Apple Store respectively. And of course the electronic reporting, which could be at the ZAMRA website, which is www.zamra.co.zm. And of course, if you're using the paper-based submitting, this is the address over there. Then in an event that you're unable to submit directly to your ZAMRA, then the forms can be submitted through any of these centers. So the ZAMRA regional offices, the regional pharmacovigilance centers, district health office, provincial health office, any responsible officer or in charge of the dispensary or community pharmacy, or it can be posted to the nearest post office, the Zambian Postal Services. Here's the form, and the form that you actually fill in the details, it's actually very, very self-explanatory when you are actually filling it in, so there's no need for us to actually go through it step by step. So what exactly is treatment failure? So it can be of three types: clinical failure, immunological failure, and virological failure. You should know these definitions. So clinical failure is where you have treatment where you consider this when you have these clinical symptoms that appear whilst the patient is on therapy, and they suggest that this patient is deteriorating. Immunological failure is going to be indicated by a drop in the Cd4 count value to below the pre-treatment levels, or 50% from the peak value on treatment, or a persistent CD4 level below 50 cells per cubic millimeter after 1 year on therapy. So these are the many definitions for immunological failure. One of them is the CD4 count should drop to below less than the pre-treatment levels. Number two, 50% from the drop below 50% from the peak value when they were on treatment. Number three, if there's a persistently low CD4 count less than 50 cells per cubic millimeter after 12 months of therapy. So patients that are initiated at a very, very low CD4 count may not actually be able to mount an adequate CD4 recovery. In this case, we can actually use the viral load as another proxy. So virological failure is when they have a plasma HIV viral load greater than 400 copies per mil after 6 months of therapy. So patients who actually appear to be failing on treatment while the viral load is undetectable should actually be considered to have undiagnosed opportunistic infections or other concomitant issues. It should be concluded that on the basis of clinical criteria that an ARV regimen is failing until there is reasonable trial of the first line for at least 6 months. You can't say someone has treatment failure if they haven't been on treatment for 6 months. So adherence should be assessed, it should be optimized, any opportunistic infections should be treated, any iris should be ruled out. Then of course clinical events that occur before 6 months of therapy should be excluded from the definition because they are often representing either iris that's going to be related to pre-existing conditions. So some factors that are implicated in treatment failure include poor adherence to treatment, prior exposure to antiretroviral treatment with development of resistance, primary viral resistance, which is you're infected with a resistant strain, inadequate drug absorption, suboptimal dosing, so sharing doses because of side effects, then of course inadequate or inconsistent drug therapy, and even some drug interactions. So here is how we manage them. So poor compliancy within 8 to 16 weeks of therapy. So we review the reasons for poor compliance and we cancel them accordingly. So what should we do? We continue the same combination or we can simplify the dosage. Then of course, poor compliancy greater than 16 weeks of therapy, we consider changing the therapy, review the reasons for poor compliancy, change 2 of the drugs. If there's treatment failure, we change the regimen. So we use drugs not used in the previous regimen and preferably new classes. If there's an adverse reaction, check the drug-to-drug interactions, stop the drugs. If continuation is of no benefit to the patient, then of course change the offending drug. Then if they're depressed, psychosocial support should be offered, so refer them to appropriate care providers. Then prognostic factors, remember that Cd4 count is a measures the degree of immune compromise and predicts the risk of opportunistic infections. On the other hand, the viral load actually measures the HIV replication rate and it also gauges the efficacy of antiretroviral drugs and also predicts the decline of the Cd4 count. So this is actually a much better proxy than Cd4 count. Now here's the algorithm for diagnosing treatment failure with our routine viral load monitoring. So we order for an HIV viral load. Now if it's greater than 100 or rather 1,000 copies, we repeat within 3 months. If still it's greater than 1,000 copies, then we should suspect that there's virological failure. So we enroll the patient in intensive adherence program, switch them to second line and ensure that there's adherence, do genotypic testing, then consult with an advanced treatment center, follow up and review them in 2 weeks, reassess adherence, side effects, and toxicity. If the viral load is less than 1,000 copies, then no treatment failure. We reassess adherence, continue current ART, treat any opportunistic infection. If the patient is still ill, examine and treat them accordingly. Now, how do we manage? So for patients that have a viral load greater than 1,000 copies and are failing treatment and are at risk of progression of HIV disease, poor adherence is usually the most common cause of treatment failure. So adherence barriers should be evaluated, we should correct them, and patients failing are actually prone to opportunistic infection, and so there should be a comprehensive assessment to rule out opportunistic infections like TB. And then when you're switching them to second line regimen, the goal is to actually suppress the virus. So it should result in reconstitution of the clinical and immunological status. We should avoid adverse effects, and of course we should optimize the adherence. Boosted lopinavir is the primary recommended second line protease inhibitor. So here's our second line drugs. So if they were previously on a DTG and a non-nucleoside based first line regimen, these are the drugs we can switch them on. TDF, XTC, DTG, which pretty much your TDF, XTC, DTG, ABC, 3TC, DTG. Then of course these ones are the newer regimens. The older regimens were TDF, XTC, efavirenz, ABC, 3TC, efavirenz, TDF, XTC, nevirapine. And of course, an alternative regimen that you can switch them, the second line, is AZT, 3TC, and boosted lopinavir or atazanavir. So this is the previous line. This is the second line that you're switching them to. Same thing with the pregnant and the breastfeeding people, because these ones are going to be on pretty much your efavirenz 400. Now, here's the preferred second line ART regimen for adults and adolescents. So if AZT was actually used in their first line, we want to avoid AZT. So we want to give them Tenofovir. So Tenofovir, XTC, and boosted Lopinavir or boosted Atazanavir. If TDF or TAF was used at the first line, then we can use AZT. So we should not continue AZT if they were using AZT. We should not continue TDF if they were using TDF. And of course, 3TC and boosted Lopinavir. I already explained why, because mutations to certain drugs predispose individuals to become susceptible to the other drugs. The virus becomes susceptible to the other drugs. That's why I said you should watch the previous video first. Then, of course, for pregnant or breastfeeding women, the same regimen is recommended for adults and adolescents if there is no previous nevirapine exposure without any tail coverage. Then, of course, if there is HIV and TB co-infection, if they are based on the rifampicin-based thing, if AZT, 3TC, and efavirenz or nevirapine was used as the first line, then we want to switch them to TDF or TAF, XTC, and DTG twice a day. If you do not have this, then use Lopinavir, boosted Lopinavir. Then, if TDF or ABC, XTC, and efavirenz or nevirapine was used as the first line, we switch them to AZT, 3TC, and dolutegravir, but we give it twice a day. If they are on rifampicin, then we can use the protease inhibitor regimens as the second line. Then, of course, those that are co-infected with HIV and hepatitis B, we actually put them on AZT, TDF, XTC, plus boosted Lopinavir. So these are 4 drugs. So TDF and XTC should always be part of the combination in all patients that have HIV and hepatitis B because it's effective. Once we withdraw these drugs, we may actually exacerbate the hepatitis. Now, here's a recommended second line regimens for HIV type 2. So if they were initially on a DTG based regimen and the regimen was either TDF, XTC, or DTG, and ABC, 3TC, or DTG, then you switch them to AZT, 3TC, and boosted Lopinavir. Remember that boosted Lopinavir is active against HIV type 2. It's actually one of the only protease inhibitors that's active. Our Atazanavir is not going to be active against type 2 HIV. Here's our algorithm for choosing a protease inhibitor in the second line. So, first of all, is there a caution to use our boosted Lopinavir? No, then we can use the boosted Lopinavir. If there is, does the patient have TB? Do they have hyperbilirubinemia? Do they have jaundice? If not, select Atazanavir. Then, of course, if they do, then if TB and on rifampicin, then DTG has not been used, then we can use DTG 50 milligrams twice a day. If there is hyperbilirubinemia, then DTG should not be used. And DTG has not been used, then we should use DTG 50 milligrams once a day. And of course, here's our guide to using Atazanavir. So we can give it once a day, 300 Atazanavir with 100 milligrams of ritonavir. We should not split or crush the tablets. And of course, it should be used in children above 6 years and those weighing 25 kg or more. Patient sensitization. So it's safe for pregnancy. We should ensure that the patient drinks a lot of fluids to decrease the risk of kidney stones. And a common side effect with the use of Atazanavir is, of course, jaundice, which is benign in most of the cases and should resolve within a few weeks. The jaundice is going to be resulting from this unconjugated hyperbilirubinemia, and largely it's just a cosmetic issue. It's not related to any hepatitis. It's not related to any liver damage, but we should order for some liver function tests to rule out other causes of jaundice. Then, of course, if the patient is symptomatic or has profound jaundice, consult the UTH Advanced Treatment Center. Then, of course, contraindications: do not use Atazanavir with rifampicin-based treatment regimens for TB. And then, if the patient is on Atazanavir with no exposure to DTG in first line and they develop TB, replace the Atazanavir with dolutegravir 50 milligrams twice a day. Do not use it with proton pump inhibitors. Substitute the proton pump inhibitors with H2 blockers like cimetidine, and it should be taken 2 to 3 hours apart with Atazanavir. So do not start patients with pre-existing jaundice or any suspected hepatitis. And I think my battery is even about to die, so I'm gonna pause the video here so that I can actually switch out my battery. Hi guys, so I'm back. Switched out my batteries before my PC actually died. So generally, we do not want to start the patients with pre-existing jaundice or suspected hepatitis on Atazanavir, boosted Atazanavir. So patients that are previously on ART, so individuals who interrupt their ART for any reason, are actually at increased risk of resistance. They are at increased risk of treatment failure. So the management in ART is reinitiating them is actually based on several factors, and a complete history should be taken why they stopped treatment. Then for HIV infected children, the caregivers must be questioned. If treatment failure or toxicity is not suspected as the reason for stopping the ART and they previously had good adherence, then reinitiate the original ART in consultation with the next level. Then, of course, if previously they had poor adherence and there is treatment failure, then these individuals or the caregivers of the children must be enrolled in an intensive compliancy adherence counseling sessions with their agreement, of course. And then, of course, they should be, when they're ready to recommence the second line, they should be started on second line. Then, of course, the use of treatments supporters for patients who is strongly recommended, as this actually reduces the risk of poor adherence. And of course, if there is severe toxicity, which is the reason for them stopping the ART, then we should refer them to the next level and initiate ART using the appropriate drug substitution or counseling regarding adherence. Then viral load testing should be done 6 months after reinitiation and original regimen to document HIV viral suppression. We do not collect viral load tests for the patient who present to care while they are not taking ART. Then what about breastfeeding and pregnancy women defaulters or failing therapy? So due to the risk of the transmission of HIV to the unborn child or in breastfeeding infants, pregnant as well as breastfeeding women who present to the care with an unsuppressed viral load or who have defaulted treatment must actually be switched to an effective therapy. Second line if they previously took the first line, or third line if they previously took the second line. Then immediately with enhanced adherent counseling should be going on. And of course, Dtg based regimens are recommended in this situation. Now, when exactly do we stop ART? So patients may actually choose to postpone or to stop the therapy, and the providers on a case-by-case basis. So it's not just for all patients. Then they may actually elect to defer or actually stop the therapy on the basis of clinical and even psychosocial factors. And some of the indications include, for example, the patient is unable to tolerate all the available ARV medication, and you should have exhausted that they can't take all the ARV medication. The patient requests actually to stop after appropriate counseling. They are not adherent despite repeated counseling. The treatment should be stopped actually to avoid the continued toxicity and also to avoid drug resistance and transmitting drug-resistant HIV. If you have an unreliable caregiver, for children, the caregiver is instrumental in actually in the ART adherence. That's a big factor. Any factors that actually affect the capacity of the caregiver to give medication consistently may be an indication to stop the ART in HIV-infected children. And then, of course, serious drug toxicities or interactions, intervening illnesses, or surgery that precludes oral intake, even ARV non-availability could be reasons. Now, how do we stop? We usually stop all the drugs when discontinuing the therapy. We discontinue efavirenz or nevirapine. We continue the nucleoside reverse transcriptase components, which are the backbone, for an additional 1 to 2 weeks. Then, of course, preventive measures should be offered, such as condom use, safe sex practices, and then, of course, it should be strongly emphasized for all patients, especially those that are discontinuing treatment. Then, of course, treatment failure with no further treatment options. So, continued failing ART regimen unless there is intolerable toxicity, so we should still keep them on the treatment. Even with treatment failure, the regimen is likely to have some residual antiviral activity, so stopping the therapy in the setting of virological failure can actually be associated with a very rapid fall in the Cd4 count, and they will develop the opportunistic infection. So when do we consult or refer them to the next level? So if they suspected hepatotoxicity not responding to the standard treatment, if they have HIV co-infection, HIV and TB co-infection, ALT and AST greater than 5 folds the limit, second line treatment failure or inability to tolerate the second line therapy, if they have complications on a protease inhibitor based regimen, if there's severe or life-threatening adverse reactions, if there's inability to tolerate therapy despite change in regimen, of course in HIV and hepatitis B co-infection with renal insufficiency. Then, of course, what is our third line? So treatment failure, we can actually define it now as a persistently detectable viral load, so greater than 1,000 copies. Of course, I gave you a value of 400 copies, but now I think let's use 1,000 copies. So for adolescents and adults, failure is a 2 consecutive viral load measurements with a 3-month interval between, with adherence support between the measurements after at least 6 months of taking therapy with 3 drugs. Then if their viral load is not less than 1,000 copies, then we say that they are having treatment failure. For children, the viral load may be detectable at 6 to 9 months after initiation, and it does not necessarily mean that the patient has viral failure. Sometimes you may have viral blips or intermittent low viremia, which is 20 to about 1,000 copies, that can occur during effective treatment, but have not been associated with an increase in risk of treatment failure unless there is low viremia, which is sustained. Now, you may get a repeat blip that should be assessed further at an advanced treatment center. Now, remember that when you're on combined antiretroviral therapy, they should have at least less than 50 copies per mil of the virus in the blood within at least 3 to 6 months. So using sensitive methods, we can actually detect the low concentrations in almost all patients that are adherent on effective therapy. So we call this as residual viremia. Even if you have as little as 1 to 10 copies, we can still detect this with other much more sensitive methods. Sometimes you may have a blip where you have these viral load results that become detectable, but at very low levels. So about 50 to 500 is a threshold that one of the researchers that I actually looked at was considering. So you can define these viral blips as transient episodes of detectable viremia in patients who are on suppressive combined antiretroviral therapy. So we have additional clinical and epidemiological studies that show that the risk of HIV transmission and disease progression is very low when the viral load is actually lower than 1,000. And of course, provision of third-line ART occurs in very rare circumstances and is actually beyond the scope of most providers. So you have to consult. So all patients that are considered for third line should have confirmed second-line treatment failure. And how do we confirm this? If there's persistent detectable viral load exceeding 1,000 copies, two consecutive of these viral load measurements within 3 months interval with enhanced adherence support, and they're taking the drugs after 6 months of treatment on second line, then we say that this patient has treatment failure on second line. Then of course we can do a genotypic resistance testing to an HIV specialist or at an advanced treatment center with a complete ART treatment history, so all previous ARV drugs that the patient has taken with the duration of use. Then of course, before starting the third line, establish the reason for treatment failure. Was it poor adherence? Was it suboptimal dosing? Was it drug-to-drug interactions? Then of course conduct an intensive adherence counseling session until you have an agreement with the patient, the provider, and the adherence counselor that the patient is ready to start the third line treatment. So it's not all patients that we just start on third line treatment like that. Then of course the use of treatment supporters for such patients is strongly recommended. The most likely ARVs to be successful in patients who have followed the national guidelines are dolutegravir and raltegravir, or Darunavia and your ritonavir, and then plus the optimal nucleoside background. So you're either your TDF plus XTC plus or your AZT plus 3TC. So other considerations that with major constraints, you may have your Itravirine, which is especially if you have the genotype genotypic testing, which is available at the time of the first line non-nucleoside reverse transcriptase failure. Although in some patients with non-nucleoside reverse transcriptase mutations that are persistent even after non-exposure to your non-nucleoside reverse transcriptase inhibitors, then of course with Maraviroc this needs like special tropism tests which should be done before you initiate the treatment, and we currently don't do those in Zambia. Now, before you switch them on therapy in suspected treatment failure, you should ensure that you rule out poor adherence. If there is poor adherence, you change the therapy only after enhancing the adherence counseling that has been conducted. If it's iris, we treat the underlying condition, we continue ART. If they're untreated OIs, we treat the underlying condition, we should continue the ART if it's tolerated. If it's due to pharmacokinetics, for example, rifampicin reducing nevirapine or lopinavir levels in the blood, then we switch nevirapine to efavirenz and then we double the dose of lopinavir, or we switch rifampicin to rifabutin. Then of course, current infections causing transient decrease in Cd4 count must also be assessed. Treat any infections if possible. Repeat the Cd4 count 1 month after the resolution of the illness for you to confirm that this patient has immunological failure. So here is the information pathway for the patients needing the advanced treatment services. Here you have the Ministry of Health. Over there you have the Advanced Treatment Center, referral, the facility, the ART facility that may be there. And of course your district medical officer and your provincial medical office rather. So this is just more or less administration work. Here's our warm-up question. A 5th year medical student has acute retroviral syndrome 3 weeks after unprotected sex with a new partner. Her HIV diagnosis is confirmed with PCR. In reading about HIV drugs, she comes across a drug called Maraviroc. Which of the following HIV-1 core receptors is targeted by Maraviroc? A. Cd4 receptor, B. T cell receptor, C. CXCR4 receptor, then of course D. interleukin 2 receptor, E. CCR5 receptor. So Maraviroc is going to be a CCR5 inhibitor. I really hope that shed a lot of light on treatment of HIV in adults. First line, second line, treatment failure, third line. If you enjoyed this video, please consider dropping a comment below, consider subscribing, hit the like button to help out with the algorithm, tell a friend to tell a friend that it is HIV week, and see you in the next video where we discuss treatment guidelines as well as monitoring of HIV in the pediatric population. My name is Dr. Moses Kazevu, to Zambia and beyond. Until next time, bye-bye.